See, bariatric surgery is a term used for surgery to reduce weight. In other words, we call it as weight loss surgery. This is not a surgery to take away the fat, but it's a surgery which will make the person lose weight. And what we do is here, there are 2-3 different methods to do it. One is a surgery where you restrict the person from eating. That means the capacity to eat is reduced. These operations happen on the gastrointestinal tract and especially the stomach. The second is you can do what we call it as a bypass, where you reduce the absorption of food which has been consumed. And third category is where you can do a combined restrict and reduce the absorption. These operations today are done by laparoscopy, that is by keyhole surgery. If you truly look at it, bariatric surgery is not new. Many years also they were done, but they were not popular that time because you can imagine somebody weighing 150 kilos in an open surgery, the cut is bigger, more difficult to operate, more chances of delay in recovery, and everything was slow and people were scared of going through these operations. But with laparoscopy coming in the last 10 years when it's become very popular, small incisions, so these patients can recover fast, the pain is less, and so it has become acceptable to patients, and that is how there is an exponential growth in the performance of bariatric surgery in the last 5 to 6 years. It's not a cosmetic surgery. See, this is something which many patients think, that they think when somebody has suggested surgery for being overweight, they may be removing fat. As I mentioned earlier, this is not an operation to remove fat. So basically, let's look at this way. This is not liposuction. This is not doing some abdominoplasty. This is an operation which is completely different. It happens on the gastrointestinal tract. And as I said, it is to make the person eat less or absorb less. So it's different. It's not a cosmetic surgery. So let me talk about success first. Bariatric surgery is the only surgery which can give you total positive results in terms of reduction in weight of an obese patient, which means it's the most successful operation for obese patients. In terms of risks, you have 2 categories. One is the general risks associated with any surgery, which is small normally with today's facilities what we have. The second is risks associated with patients who are obese. They have their own risks. Their size is bigger. You can start from there. The OT needs to be very well equipped. The table needs to have sufficient capacity to take the weight. The anesthetists need to be well experienced. And then you have risks. The risk should not be more than 1%. We want to have risks less than 1%. So what we do is, we will assess these patients fully before surgery, evaluate them completely, have the anesthetist assess them, and make sure the risks are minimum before we take them. If they have other associated diseases along which go with obesity, like diabetes, blood pressure, heart diseases, they become higher risk. In such patients, we have to think before doing, because at the end of it, these are patients who are fat, they're obese, they want to have surgery to get better. From medical point of view, we tend to tell them it's a life-saving operation because obese patients don't live longer because of multiple diseases they develop. But as far as patient is concerned, they won't be thinking in those lines. So everybody wants success. So if the risks are higher, we may avoid or we may think about it, explain to them and then take it. Otherwise, on a normal basis, I do not expect anything, it should be less than 1%. We would have been prepared for it. Occasionally we do have problems of, it can be technical problems in terms of sometimes leak developing. There can be thrombosis developing in these patients. Obese patients are more prone to that. They can have respiratory problems because of respiratory issues which can come up. These are the usual things which we should be prepared to take care. You see, when we talk about patients going for surgery, there are certain selection process. We don't want to operate on everyone. That's number one. The number two is that we want to operate on patients who are actually obese, and there are certain criteria. We talk in terms of BMI, that's called body mass index, which is calculated from weight and height. And we would like to do in India, we do not want to do anybody below 30 BMI. So that's the first thing, so that you don't do below 30 BMI, it's all above 30 BMI. And when you go above 30 BMI, you talk in terms of people who are having diabetes, about 30, otherwise it's all about 35, where you go for bariatric surgery. So this is criteria, what we take for doing surgery. Once you have decided on surgery, to tell the patient, now the patient part. Patients don't come so easily to surgery straight away. And we, in the treatment group, surgery is not the first option. The first option is to find out, evaluate the patient, evaluate the reasoning, and then counsel them and put them on a diet and some exercise. Diet is the most important part. If you look at all of us, we are not people who will go and exercise hours together. Most of the people working may exercise half an hour, 3 times, 4 times in a week, but they are not unlikely to be exercising like sports people or some of the celebrities who do 4 hours or 5 hours. It's not practical. So we want to put them into good habits, take them through a dieting program. Only if they fail, then you start looking at surgery as an option. So I think what we want is, surgery is not the first option. Surgery should be the next option if others have failed. So if you look at patients, most of them, they scout around. They have done first time comers. I'm not seeing many first time comers. I tend to see people who already gone to few people. They've already had trials with dieting. They've seen surgeons and they've come. It's not, I don't think it's an easy decision for most of the people. Some of them may have made up their mind, and I do see some of them who have come prepared. After having gone through some people, they have come prepared. But otherwise, generally, they take few visits, they try to understand, they know that diet has failed, and then they look around, and then they ultimately plunge for the operation. It also is one surgery where today insurance is not covering so far. Because what insurance feels is, they put it as pre-existing problem, it continues. So far, insurance has not accepted this as one of the procedures where they would reimburse or pay. Having said that, cost is a factor. Because when you do a surgery on patients who are obese, everything becomes more. You need a good operating theatre, you need a good anesthetist, you need good equipments, and we tend to use disposables for this surgery. A lot of disposables are used. Disposables are like when you cut and stitch, we use what are called as staplers. And it's a lot of disposable. We may use some glue for fixing. Everything is expensive. And these are all imported things. So I would think you cannot compromise on materials in doing bariatric surgery. So the awareness has to come in the medical community. They can bring the awareness to them. Then they will come to know about bariatric surgery. You see, this is not something which is widespread at the moment. It is still in pockets. It is the medical fraternity who need to understand, the physicians, the family practitioners, the other specialty. Obese patients are seen by every specialty. Not for obesity, for something else. You can have a physician, because they have other problems. You can have medical problems. They can have gynae problems. They can have various problems of various systems. So they'll be seeing various doctors. So each doctor can look at it, obese patient. Is there something can be done? So a specialist should actually work as a family practitioner when he sees some other. I'm a surgeon. If I see somebody having some problem, I can guide them what to do. I know there is a problem existing. It may not be a surgical problem, but I can guide them. Okay, go to a dietitian. They have come for some other problem, not for bariatric surgery, but I can guide them. Look here, you have these problems. Why don't you start doing some dieting? Why don't you look at physiotherapy? Send them to a dietitian. So it's awareness. So it's one side public, one side medical fraternity, and the patients themselves. So I said today the numbers have increased and acceptance is increased because it is done through keyhole surgery. Let me say what is keyhole surgery. We call it as laparoscopy surgery. We call it as minimal access surgery, or it is overall weight loss surgery goes to keyhole surgery. Because it is done through small holes where we use some special instruments, the recovery time is totally different, much quicker and much easier than compared to a big cut which would happen from open surgery. So one, the overall recovery time, pain is reduced. You can mobilize these patients faster. There are a lot of changes in our approach to today's surgery. We feed the patients within 3 to 4 hours. We start them on some liquids, water. We mobilize them in about a few hours' time. And then we have good pain relieving medicines, not making them sleep. And so these patients tend to recover faster. And especially when somebody is on the heavy side, we want him to move faster. Otherwise, the chance of complications are higher. We don't want them to lie down in bed for a few days. So it's quicker. Telling this, it gives me, and all these surgeries are done under full anesthesia. So the whole concept, from going to big cuts and delayed recovery, we are going to small cuts and quick recovery. This concept brings me to tell you, there is a term called ambulatory surgery, which means that you do the operation, ambulate is move the patients and send them home fast. Various categories are there in this. You can treat in outpatient, you can admit and discharge on the same day, you can discharge in 1 or 2 days, you can discharge in 2 or 3 days. So it either is outpatient surgery, day surgery, or short stay surgery. This all put together goes into ambulatory surgery. Ambulatory surgery became very popular in the United States and got started there in the 80s. If you look at India, people do ambulatory surgery in various hospitals, but it is not one of those popular elements. This brings us basically a short stay ambulatory surgery center. Big difference here and in big hospitals, these are independent centers. Well equipped, state-of-the-art independent center where you will find that patients find it easy to access, easy access to meet people, easy access when they come to get things done. You don't stand in a queue, you don't wait for admissions. And we tend to fast track or speed up every aspect in surgery. The whole system is geared up with doctors, anesthetists, nurses, all geared up. And so we admit the patient, and this laparoscopic surgery is one of them which has been taken up by NOAA as a short stay surgical procedure, where we send them, depending on the procedure, ranging from 1 day to 3 days, they get discharged. Most important is that more than reducing the cost, because these are very clean, neat, only place meant for planned surgeries, the chances of infection and chances of problems are much less than other bigger places where they take up all variety of cases, because they are, whereas here we are selected surgical centers, you do clean operations, and so the chances of problems are less. And you discharge the patient faster, and you do select the patients. And so these are well-equipped centers. We do 2-3 programs. One we do is a patient awareness program, where we run camps once in few weeks with multidisciplinary approach. We have doctors, we have endocrinologists, we have dietitians, we have physiotherapists, and bariatric surgeons who would see patients who are obese and give them guidelines and help them to make decisions on whether it's diet, whether it's exercise, how to go about it, and talk about surgery. This is one. The second thing is we need to educate our own patients, and we find some of the patients are the biggest promoters of bariatric surgery to other patients who want to have. So we have patient group meetings. That is, post-surgery, we have patient group meetings and get other patients who want to see them, because patients would like to be convinced by seeing patients who are having a talk to them. So we are creating patient groups. And so that way the awareness builds up, and it makes it easier for a patient who is thinking about surgery to take decisions. Because when they see few patients who have gone through, find out from them how good, how bad, and they like. And it's very interesting, in bariatric surgery, we make the patient eat less, I said. But interesting part is, none of them complain they're eating less. They're all satisfied. Satisfied eating. So, though the quantity is reduced by 80%, they feel satisfied, because when you do some surgeries, internally, there are a lot of hormonal changes which take place. And these hormonal changes are responsible for killing the desire to eat. So that is a big advantage in these patients. The second thing is, you find today, diabetes has become a big problem in the country. In about another 10 years' time, we may have the distinction, India, being the #1 in diabetes in the world, because the present forecast for India is diabetes is going to be the #1 in the world. So diabetes is increasing in a big way. Diabetes can go with patients who are obese, or diabetes can be there with patients who are not obese. You've got type 2 and type A diabetes. Those who are obese, once they undergo bariatric surgery, in 80% of them, the diabetes disappears, because it is related to weight. So this is also one of the ways of treating patients, curing diabetes by reducing their weight. Patients don't want to tell they have undergone bariatric surgery. Many of them hide. But some of them come in open and say, frankly, and this is what is important, because they share that they've undergone the operation. Once that has happened, then they're open to talk. They can compete. Some of them can compete with models. The whole aspect changes. It is real joy to see the patients who lose weight and how they enjoy it. Recently, one patient was telling me that she used to dance. She's gone back to Kathakali dance. And she says now she can dance. She can go back to doing some things. People find it very easy to get into their car. They can drive nicely. I told you about ready-made shirts, how people can get into. So all these things which are there in their dream, it starts becoming true. So that's it's a joy to see them. And I told earlier, they eat and they're satisfied. They eat less, they eat satisfied. It is not that they feel that they eat less. They don't feel at all. Recently, in one of the conferences, I was quite amazed. I saw two surgeons who have suddenly become trim. So, looking at them, I knew, oh, these people must, these are surgeons who perform bariatric surgery, and they performed on each other. And they look totally different people. They are, the joy is there, the smile is there. And see, everybody wants to, so they felt that they should undergo. I mean, I didn't ask the reasons, but when I put them point blank, they said yes, they have undergone surgery. They didn't come out and say they have undergone, but they have undergone. So, you see, that means it's there. It's a surgery which is now accepted more and more. And as you see in the next few years, more number of people will start learning and doing, and it is going to become an important group in India. Because I said, number of obese patients will increase, number of surgeries are going to increase, it will get more refined, more people will come, more centers will be there, and you will see more patients coming forward and saying that they have undergone this surgery. That's when the awareness will increase.